the lines are up a bit. So welcome to the first breakout session of Core NTD this year. You are in the session Moving Beyond Business as Usual to Address Never Treatment for Mass Drug Administration for Lymphatic Filariasis. So I'm going to go ahead and start my share my screen, and we'll go ahead and get going. We have a fairly full agenda this morning or afternoon, depending on wherever you are. Great. So without further ado, I will introduce us to the session today. My name is Alison Krentel. I'm calling in from Ottawa, Canada. I'm at the Bria Research Institute and the School of Epidemiology and Public Health at the University of Ottawa. And I'm really delighted to be here representing my co-organizer, Dr. J.M. D'Souza and Molly Brady. So I'm just going to take about 3 minutes and introduce you to our session today. So I just want to give you a quick update. We have been having this conversation for moving on to 2 years now. And some of you will be very familiar with some of this timeline, but just to kind of give you an idea of what's been going on in the background around this issue of never treatment. So we began with research review meetings in December of 2020 and January of 2021. These were opportunities to understand what was being done in the community, in the research community, with partners and programs. And we moved in to present these back to the wider NTD and LF community in May of 2021 with a research links session that some of you may have attended. From that point, a year ago at Core NTD, we consolidated the use of the term never treatment and really presented an overview of what had happened over that past year. So since that time, we've seen a fairly consistent agreement on the use of this terminology. And if anyone is interested on the background of that, I'd be more than happy to talk with you offline on that. In addition to that, through ICORDS, a community of practice, a small task team worked on the refinement of a guidance document to include never treatment questions and routine programmatic data collection tools, and you're going to hear what that looked like from our colleagues in ACT West and ACT East today. That document is available for download on the ICORDS website, and I'll be happy to post that link as the session moves on today. Since last year, the Modeling Consortium has been working on the importance of never treatment and LF elimination. We won't be hearing those results today, but they've been working on various models to understand what levels of never treatment, how they might affect overall rounds of MDA. We've also seen the inclusion now of the never treatment question in our routine data collection in several sites, which has been really exciting because we're able to understand what this can look like and also how feasible and acceptable it is for programs. And finally, just really new off the presses, some new operational research that will be funded through Core NTD. So today's session, we're really focusing on 3 research questions. How can never treatment and LF MDA be identified using routine programmatic data? What factors are associated with never treatment? What do we know? And what do we need to know more about? And also, are individuals who self-report never treatment also more likely to be antigen or MF positive, and looking at some of the results from that. So we're going to hear from three different sessions right now. We're first going to hear from Molly Brady and Ernest Mensah from ACT East and ACT West, and they're going to share with us what measuring never treatment looks like within using routine M&E tools. Then we're going to move on to J.M. D'Souza from Noguchi Memorial Institute for Medical Research at the University of Ghana, and he will share some results from his work on examining infection levels and understanding non-compliance to LF MDA among never treated in Ghana. And finally, we'll hear from Christiana Titali at the Faculty of Medicine at Patimura University in Indonesia on a recent study on exploring the social and behavioral factors associated with never treatment in Ambon City, Indonesia. So I think you're in for a treat today. All three talks are really interesting, and I'm looking forward to hearing your questions and comments. So following the three sessions, we're going to have a breakout rooms. And this session is about thinking outside the box and thinking beyond business as usual. So really want to encourage everyone in our smaller breakout rooms to think creatively along these three questions on how we address who is systematically missed, what are the system level barriers and opportunities to address never treatment, and what are the ways to collect, analyze, and use routine data on never treatment. So consider those questions as we listen to our next three speakers. So thank you very much and welcome.
Hello, my name is Ernest Mensah. I am a regional NTD's technical advisor and LF focal point at FHI 360, working on USAID's Act to End Neglected Tropical Diseases West program. My co-presenter today, Mali Brady, is a senior LF advisor at RTI International, working on USAID's Act to End Neglected Tropical Diseases East program. From July 2021 to August 2022, we supported ministries of health to collect the never treatment data in 93 districts in 8 countries in pre-transmission assessment service and coverage evaluation service. The data was collected using the standard question, including this MDA: how many times have you swallowed LF MDA drugs? There was also a follow-up question for those who responded never to identify possible reasons for never treatment. While the data was collected mostly in LF activities, we also included this question on coverage surveys for onchocerciasis in Tanzania and trachoma in Uganda. And note that in Sierra Leone, Burkina Faso, Ghana, Nepal, and Tanzania, the pre-TARs were repeated pre-TARs. Here we present the overall results. In the pre-TARs, we use results from everyone answering who is older than 5 years, regardless of whether they were answering for themselves. While in the coverage evaluation surveys, we only use results from those answering for themselves and old enough to be eligible for treatment. Example, older than 5 years for LF. We will focus on the last column, reporting percentage of people never treated. The percentage of people never treated was from an average of 1.5% to 29.3%. For pre-TARs, the range reflects percentage of people never treated by survey site, while for the coverage evaluation survey, the range reflects percentage never treated by district. Within countries, the range varied by site, leading to the need for localized solutions for engaging with those never treated. In Burkina Faso and Ghana, the question was only asked to people who tested antigen positive in the pre-TARs. In terms of feasibility, we found that the question was relatively easy to ask and collect data on. Planning. This was aided by the one-page guide developed by the ICOR's Never Treated Tax team. Countries, including the question in survey protocols and in electronic data collection tools. data collection. However, teams did note improvements that could be made to better capture the data. Interviewers didn't always use the exact same language when asking the question and didn't necessarily probe respondents, especially around reasons for never being treated. All this could be improved with more emphasis in pre-survey training on how to ask the question. Showing samples or photos of the drugs when asking the question is important. The question was adapted slightly by certain programs. For instance, in Nigeria and Burkina Faso, they asked, in how many of the last 5 years have you taken medicines for lymphatic filariasis, instead of asking about all years. In the Tanzania Coverage Evaluation Survey, the question was modified to note the month of current MDA round. Perhaps not totally unexpected, as this was not a study to validate the question, but programs were implementing normal survey activities. Data analysis and use. In the coverage surveys, cross-checking the answers between this question and the existing coverage survey question, did you swallow the MDA drug, showed discordance in a few cases where respondents who might have misunderstood the question answered yes to the first question and being never treated. In general, programs found this useful and were able to use this data as another piece in the puzzle when improving social mobilization and targeting of MDA and supervision.
Thanks, Ernest. In Indonesia, the never treated question was routinely asked in the 20 districts with ACT East supported pre-TAS. In these districts, 40 sites were included, with 12 of these sites being classified as urban and 28 as rural. As none of these pre-TAS failed, we instead compiled and analyzed for trends in never treatment data at the national level. As you can see from the graph on the left, a higher percentage of men than women were never treated in both the rural and the urban sites. Men had similar levels of never treatment in both areas, 24% in rural sites and 25% in urban sites. However, urban women were significantly more likely to be never treated than rural women, with 22% of urban women responding that they were never treated. Participants were also asked, why were you never treated in LF MDA? And were asked for one reason why. As you can see from the graph on the right, 28% of the never treated participants in rural areas did not give a reason why they never took the LF drugs, likely due in part to a lack of probing from the surveyors. But new to the area and absent during MDA, those reasons were more common among the participants in rural areas. On the other hand, more common among the urban participants were access reasons in terms of just not receiving the drugs, but also refusal issues such as afraid of the side effects of the drug, not wanting to consume the drug, and having other health issues. From this data, as well from other evidence, the team recommended in urban areas with ongoing MDA to focus on women and to improve health promotion around LF disease and drug safety, especially around who is eligible even if they have other chronic diseases. In rural areas, however, improvements in the timing of MDA in terms of the month and day, it was thought perhaps that could yield better reach to those never treated, and with a focus on figuring out times and places where men would be most available. On the other hand, in Nepal, the national program used site-specific data to advocate with decision makers and to improve MDA. For instance, in one site in Banke district, Nepalganj, which is a very urban site, 34% of people were found to be never treated when they were asked that during the pre-TAS, and this was even after 11 rounds of MDA. 34% of the adult men had been never treated and 28% of the adult women. 9 people, or 2.8% of those tested, were antigen positive in this pre-TAS, which meant that it failed and more MDA was needed to be done. 7 of those 9 positives were men, and 4 of the 9 had never been treated. The very high level data on the percentage of never treated, the 34%, helped convince social leaders, elected bodies, other planners that MDA was still important, despite fatigue from many years of treatment, and that MDA needed to be improved. Even if there was some debate on the power of the data generated from a small sample, it still worked to be able to help show the problem and to convince the leaders and those responsible for MDA that it was still needed. Some leaders asked further questions about this data. They wanted to know the literacy level or the ethnicity of those never treated, wanting to get a fuller picture of who was in this group. In the most recent MDA that was done after pre-TAS, after the advocacy to social leaders, elected bodies in Nepalganj, and trying to mobilize community leaders, including sharing this data with them, the LF program also did microplanning and enhanced supervision, including using the supervisor coverage tool to monitor coverage during MDA. As many of the districts included in this presentation had implemented quite a few rounds of MDA before the survey, some as many as 19 in LF areas and 28 in onchocerciasis areas, a question came up where we wondered how important is it to be ever treated versus treated recently. If someone was treated once or twice 10 and 11 years ago, do they still count as someone who has been treated, and what's that impact on ongoing transmission? In addition, given that we in some countries saw high levels of never treatment in certain sites, but still these sites past pre-TAS had low enough prevalence, how important is never treatment versus other factors such as baseline prevalence or type of vector? And just to note that we're continuing to support national LF programs to collect the never treatment data, including improving the training of surveyors on data collection and analysis and use. And we look forward to the outcomes of this session in determining other ways that we can strengthen this endeavor. Thank you very much. We look forward to any questions that you might have.
Thanks very much. I think we'll go ahead and move on to our next speaker, Jejem de Souza. And then if you can just hold your questions until the end. I see that some are coming up in the chat box, so thanks very much for those who are going ahead and putting some questions in. Emily, are we able to roll on to the next video?
Good morning, good afternoon, and good evening, depending on your location. This is a presentation on our work that was published a couple of months ago, but with some additional exploratory analysis. MDA for LF faces so many challenges, including health system and sociocultural challenges. For the purpose of this presentation, we'd focus more on non and never treated, who are people who miss yearly MDA for reasons of fear of side effects, low risk perception due to the lack of visible signs and symptoms of the disease in the community, travel or other commercial activities, migrant populations, illness, pregnancy, and other reasons. To address the LF endgame challenges of non-never treatment, we conducted this study with the aim to reduce the reservoirs of W. bankruptcy and improve coverage by intensifying the identification, engagement, screening, and treatment of individuals who seldom or always miss MDA in a hotspot district of Ghana. The study was conducted in the Ahanta West district of Ghana with 17 years of MDA. A formative study to understand the needs and challenges of non-treatment was undertaken with participants who regularly take part in MDAs in one group and those who don't in another group. Following this, two strategies were implemented. An engage and treat strategy, where CDDs use MDA registers to identify non-treated in the community and engage them to accept treatment, and a test and treat strategy where those who refuse to engage and treat were offered testing by community health nurses and further engaged to receive treatment if positive. Here is an example of a community member who consistently refused treatment. A process evaluation was conducted at the end of the study. Almost 27,000 people were reached after the MDA. However, the analysis focused only on close to 24,000 due to challenges in the first month of the study. The non-treated ranged from 5 to 98 years. 78% of those reached were not captured in the MDA registers. And most of these were identified through a snowballing approach where individuals who were identified in households pointed to other individuals who do not take part in treatment. 75% of the non-treated accepted the engage and treat strategy. Of the remaining 25% under the test and treat, almost 99% were positive for W-Bancrofty antigen, tested using the filaria test strips. Almost 96% of the non-treated accepted the FDA drugs. The remaining 4% refused the treatment, including 3 FTS positives. These tables just show the antigen prevalence between males and females and in the different age groups. Very high prevalence was observed among children 5 to 10 years. Despite the confidence intervals, which are quite large due to the numbers tested, this could be indicative of transmission in the district. The antigen prevalence was only in a handful of communities. In some of these communities, prevalence as high as 90% could be observed. These communities can therefore serve as the focus for further surveillance activities. Based on this data, we extrapolated for the entire district to identify areas that may require additional interventions. Looking a little closer to NEVA treatment, a follow-up survey to understand NEVA treatment was conducted through a cross-sectional survey. Respondents were selected from the database created during the engage and treat and test and treat implementation. Due to limitations of the MDA registers, NEVA treated are defined as those who missed the last 3 MDA and were captured in the test and treat group. Majority of the NEVA treated reported being aware of the MDA activities with reasons of fear of adverse events, dislike for medicines, low risk perception, travel and occupational activities cited for those not taking part in the MDA. 14% of the NEVA treated reported never taking the drug before our intervention. Those who missed MDA for fear of adverse events, being unaware of MDA and refusing MDA, are highlighted as the most likely groups to be NEVA treated. Of the FTS positives, 54% missed the last 3 MDAs. We also requested the coverage data from the NTD program, but the program data coverage at the end of the MDA before the study was 88.5%. However, given the number of people reached and not captured in the registered, we re-estimated the program coverage to be 76.3% or less, assuming there are more people in the district not reached. We also estimated the coverage after our intervention to be 108% with an increase of close to 20% from the program coverage. Despite not being experts, we tried using the online transfield tool from the NTD Modeling Consortium. As such, these results should be carefully interpreted and we'll be happy to work with the NTD experts to refine this. However, depending on variations in the models, conducting an effective engage and treat or test and treat will save 1 or 2 additional MDAs in order to reach the interruption thresholds based on the antigen prevalence levels observed. There are indications from other studies that the main vectors in the study districts, Anopheles mellas, exhibit the vector-parasite interaction processes of limitation. As such, this could be further considered in further models. In summary, we see a significant number of people who are not reached during the MDA. We also see a significant antigen prevalence among those refusing treatment. The implications of these in terms of interruption of transmission and potential recrudescence are not clear. Overall, there is an improvement in the treatment coverage. The findings of this study also provide opportunities to improve treatment activities and surveillance pre and post MDA. I would like to thank the following, especially QRNTD Ghana Health Service and the UK Aid for their contribution towards the study. Thank you.
Hello everyone, my name is Christiana Titale. I'm working in Faculty of Medicine, Patimura University in Ambon, Indonesia. Now I would like to present the results of our analysis titled Factors Related to Individuals Who Were Never Treated During Mass Drug Administration for Lymphatic Filariasis in Ambon City, Indonesia. This is the background of Indonesia. Indonesia is one of the largest LF endemic countries in the global program. Efforts to address LF in Indonesia began in 1975. In 1980, the microfilaria rate in Indonesia was 19.5% and decreased to 4.7% in 2015. There are several challenges for LF elimination in Indonesia through MDA. This includes high population mobility, diverse socio-demographic characteristics and education levels, a lack of awareness of LF in the community, the persistence of a coverage compliance gap in some areas, and the limited budgets provided for MDA at the district level. How about in Ambon City, Indonesia? In 2009, Ambon City, Maluku Province initiated its annual MDA using DEC and albendazole. However, in 2015, Ambon City was required to conduct another 5 additional annual rounds of MDA. In 2016, Faculty of Medicine Patimura University conducted a small study as a preliminary research in 2 areas, Waihaong and Air Salobar. We found that only 63.7% of population who received the drugs swallow LF drugs. It was around 133 people of 210 people surveyed in our study. And in the second areas, Air Salobar, only 49.3% people swallow drugs. This is like 104 out of 210 people who receive LF drugs. Therefore, in 2018 and 2019, the Faculty of Medicine, Patimura University, in collaboration with the US CDC and the Bruyere Research Institute Canada, conducted a study aimed at improving treatment coverage and reducing the coverage compliance gap in MDA for LF. And this analysis used data from 2 cross-sectional surveys aimed at examining factors associated with never treatment during any MDA rounds to better understand the prevalence and drivers of never treatment. The methods used in our study: we use information from respondents aged 18 years or above, and the study outcome was individuals who self-reported never treatment during any round of MDA. We conducted the study in Air Salobar and Waihaong Health Center's catchment area, and the study was conducted in 2018 to 2019. All potential predictors were grouped into socio-demographic, health system, therapy, and patient-related factors. We employed logistic regression analysis to examine factors associated with never treatment in any year of MDA. We analyzed information from 1915 respondents, divided into 951 from the baseline and 964 from the end-line surveys. The sample size used in our study detect a mean difference in the mean behavioral score between compliers and non-compliers, which is 1.0 points on a 5.0 point scale with a standard deviation of 2.5, assuming a two-sided alpha of 0.5 and a power of 80. We use a two-stage cluster method, and 20 sub-hamlets were selected at each site using the PPS method. And from the list of all households in the selected sub-hamlet, 25 and 23 households in Air Salobar and Waihaung, respectively, were selected. And from selected household, we only selected one household member randomly. These are the variables analyzed in our study. The dependent variable is never treatment, defined as individuals who self-reported never treatment during any round of MDA. And independent variables were categorized into 4 groups: socioeconomic factors, health system-related factors, therapy-related factors, and patient-related factors. Overall, there were 38 variables identified as potential predictors. We used the least absolute shrinkage and selection operator, or LASSO, to select predictors included in the regression model. So at the end, we had 9 variables and all socioeconomic variables. We used multivariable logistic regression analysis using significance level of 0.05. We used the SVY command in Stata to take into account the sampling probability used in our survey. And these are some results. In total, our analysis found that 41.78% of 1915 respondents reported never treatment during any round of MDA. And as we can see in the graph, more people reported never treatment at the baseline survey, around 54.57%, than in the end-line survey, which was around 29.15%. The odds of never treatment from our multivariable logistic regression, the odds of never treatment increased in respondents who work in formal sector compared to the housewife. It also increased in those who perceive vulnerability to adverse events, either neutral or possible or very possible. The odds also increased in respondents who reported some difficulties to remember to swallow LF drugs. And then the odds also increased in respondents who thought no one in the family participated in MDA for LF. We also found there are several factors significantly associated with reduced odds of never treatment. Respondents at the end-line survey has a reduced odds compared to those from the baseline survey. And respondents who perceived half of the family members or almost all of the family members participated in the MDA for LF had a reduced odds compared to those who were not sure whether the family participated in the MDA for LF. And respondents who were sure about how to take LF drugs had a reduced odds of never treatment compared to those who were not sure about how to take LF drugs. These are some couple of pictures of our data collection. There are several main important factors found in our study. The first one is the fear of the side effects. This might reflect the influence of rumors and potential lack of care when side effects occur. Thereby, it is important to have a system in place about what to do when side effects occur. This will reduce fear and improve trust. The second was the importance of improving self-efficacy. Almost half of the respondents were not sure about how to take LF drugs. Therefore, giving clear instructions about how to take LF drugs is very important. The next issue is social capital. Household clustering may exist for never treatment. This might be related also to the knowledge and awareness. Therefore, it's important to identify geographic areas for never treatment as well as conduct training of drugs distributors to identify NAFR treatment. This research suggests the benefits of monitoring NAFR treatment in addition to routine MDA coverage measurements. Further assessments of the use of the NAFR treatment indicator to measure improvements to MDA is recommended in areas where higher levels are known or expected and should be combined with existing measurement of coverage. There are some limitations in our study. The differing levels of recall between the baseline and endline survey, as the baseline survey was carried out 6 months after the last MDA, while the endline survey was conducted 1 month following the 2018 MDA. The interviews were based on respondents' recollection and could not be validated. There might be other potential predictors for NAFR treatment during the MDA not included in our analysis. And our study team could not assess the impact of the study itself on the improvement of coverage in the study areas. And the study design did not allow us to draw causal links between factors analyzed and NAFR treatment. We concluded that efforts to improve coverage and compliance should consider NAFR treatment. Efforts to reassure community members about side effects are important to promote uptake during the LF MDA. The health sector's role, including drugs deliverers, to convey specific messages to the community, such as instructions on how to take the drugs, are essential additions to social mobilization. Raising awareness in the community that participates in the MDA is part of one's contribution to the health benefits of the household and the community is an important consideration for MDA uptake in Ambon, Indonesia. Thank you very much. Terima kasih.
Excellent. Thank you to our speakers. And I'd like, if you're able to turn your cameras on our speakers, Ernest and Molly and Jajem and Christy. It'd be great to see your faces here. And I think if we were in the room, there'd be a great big round of applause, but me and my office alone probably isn't sufficient. So well done, everyone. And thanks for bringing up some really important issues. There's been some excellent questions and back and forth that's been going on in the chat that I've paid attention to. But I want to just give a chance. We've got about 10 minutes for questions before we go into our breakout rooms. And I see there were 2 questions that I see were kind of hadn't been addressed in the chat. So I'm going to start with those. And then if there are other questions, please do put your hand up or include them in the chat box. So the first question was actually one of the first ones from Dr. Ashok Agarwal. What were the reasons for gender differences among never treated, particularly in Indonesia? And I think that came, Molly, from the piece that you presented. So I'll hand over to you to take care of that one to start with.
Sure. I can say a little bit, and then I welcome my colleagues from Indonesia to jump in. I see that Hertie is here, and she has a lot more of that data than I do. I think in terms of the reasons for never treated by gender, most of them I think were relatively similar. The one thing that I think more males said was that they were away, and that was the reason for not being treated. Hertie, do you want to add anything to that?
Yes, I think like it's right that like we still like working on the data for that cluster, that batch of data, and I think like half of it did not also like given reasons, so that's why I'm not really like very sure to validate. But from what we see, like more males never treated said that they are away because they work sometimes like they work in the forest, or they're just like not in the area. I think, but I think like it's various because like in some areas, some other site is female are more not treated compared to the male. So I'm not really so sure to answer that. That's why like yeah, we still need to finalize the data analysis. Thank you.
Thanks, Herté. And I think you raise a really interesting point that it's variable. And I think in JGEM's data, if my memory is correct, there was also at one point, I'll let you comment, JGEM, so I won't answer for you, but I believe there was some gender differences in some of your research as well.
Yes, definitely. In our studies, we see a lot more females being never treated than males. The reasoning for that, I think we need to probe a little bit more, but in some cases, there were reports that the husbands, the men in the house refused participation, did not give permission. Some were due to pregnancy, breastfeeding, but I think there's a need for a bit more probing in order to properly understand that gender bias.
Yeah, thanks very much. And I think it's something that as we understand local context better, we'll see some variation in that depending on where we are, but something certainly that has come up in some of the research that's been done. I just want to also, I was going to highlight the last question there about seasonality of MDA. And I think JGEM, you've responded there, and Molly has as well. Would anyone like to comment a bit further on seasonality of MDA beyond what was in the box there?
Yeah, hi, Alison.
Yes, please.
I think that, yeah, seasonality has been very important from other studies that has been done, especially for rainy season, which in the forested areas can be so heavy. And therefore, if it is done at that time, the CDDs have limited opportunities to move around and distribute the drugs. And this also is aggravated by the CDDs being given limited time to conduct the MDA and report. Sometimes in some communities, there are seasons where planting season, farming season, harvesting season, these are no-go times because they would have to go, including the CDD himself or herself would also have to attend to their personal business. So this definitely has implications for whether people are treated or not. So this becomes more pronounced in places where there have been just a few MDAs which were not cited or were not planned at the right time. But if you look at places where they have had a lot of MDAs, like 10 plus, you will find that it sort of balances out and the numbers or proportions are few, but definitely the season is an important factor.
Thanks, Ernest. And you've hit on some of those really important also systems related issues. And I think for those of you that will be joining that second breakout group on what are system level barriers and opportunities to address never treatment, I'd like you to remember some of what Ernest has said, because I think these are important when we think about how to address never treatment. There's a question here on the validity of measuring never treatment, and does it depend on cultural and other factors? So I think we've heard from a lot of different locations today, just in the presentations that we've had in the last 30 minutes. But I'm wondering if anyone has a comment on that, on how, and I don't know if there has been some other research that's been done on sort of measuring, validating this measure against registers, but I don't know if anyone would like to jump in and just address that question in terms of the use of the question and how you find it's performing, given the context. I know certainly, I don't know, JGEM, do you want to talk about it on the basis of the registers? If you have any experience on that side?
So I think this varies depending on the setting you find yourselves in. In our study, we use a register that's that can take 5 years of data at a time. And so we limited our activities, our study to the current register. The previous registers sometimes are not available, sometimes they are not properly stored. That's another challenge altogether. And so the validity of this has to be considered very carefully. We have to look at what is available in each settings. Even in Ghana, where we did this study, in some particular areas, registers were not available, but they used tally sheets. So then we had to focus on those tally sheets in order to understand, to identify who is treated, who is not treated. And so it has to be considered very carefully. The validation of it, we're currently doing a second phase, just to show that what we did in the first phase is replicable in another setting, in another district. And so after that, we could see whether this is one way to go, or if there is a need for other considerations to be made.
Thanks, Jejam. And just to comment further on that, I think that we've seen in the various locations where it's been tried that the questions performed really well. And when we look at it against other indicators and variables, it does perform consistently. So I think increasingly as it's being used, we understand more how it performs both in the routine programmatic data and also in the research. I just want to go to you, Christy. I hope you're there. I know your camera's off, but one of the things that you raised, which I think is interesting and it didn't come up in the other presentations, was around this issue of self-efficacy. And I wonder if you could speak a little bit about what you found in Ambon, particularly around how to take medicines despite many, many years of MDA, and if you could speak a little bit more about that.
Yes, thank you, Alison. Maybe before talking about that, I would like to address James' question as well. James asked about whether we collect information regarding healthcare workers. Unfortunately, we didn't collect much information about the healthcare worker thing, but we asked the respondents about the level of trust they had towards the drug deliverers. And in our modeling, the logistic regression, it's not significant, like the level of trust towards drug deliverers. But I think maybe that's the only question related to the health workers that we ask in our questionnaire. And about the self-efficacy, yes, thanks, Alison. So it's very interesting that the results shows the role of the self-efficacy, especially regarding the level of confidence of the respondents about how to take the drugs. Like most of the respondents were not aware what's the correct way of taking the drugs. So like some of the respondents might take like 3 DEC and 1 albendazole across 2 weeks or across the whole month, like once per week. And or some were not aware that they can chew albendazole, for example. And so it's like lots of uncertainty, because some health workers even advise the community to take the drugs before going to bed, just to avoid all the adverse events that may happen, and prefer rather than taking the drugs in front of the drug deliverers, for example. So there are lots of uncertainties going on in the community, and that also leads to the never treatment based on our findings.
Thanks, Christy. And I think it highlights, some of the assumptions we make, that people just simply understand how to take the treatment, and also the importance of directly observed therapy. So I want to thank our speakers for presenting so beautifully today and helping us to really dive into this issue a little bit more. We're going to go into our breakout rooms. We're going to have 7 rooms, and you'll be randomly allocated into these rooms. And in each one, there'll be a moderator who will help to guide the discussion. We will be using an easy retro board. For those of you who don't love that, that's okay. You can just talk and we'll capture what you're going to say. So we're going to have about 25 to 30 minutes in the breakout rooms, and then a 1-minute lightning rod report back. and then we'll wrap up the session. So Beth, over to you to push us into our rooms, and we'll see you all on the other side. Thanks so much, everyone. Welcome back. I have to say, I do miss the chats in the hallway. But anyway, so it goes. Hopefully our lab watched the opening plenary today together. So hopefully some of you are having some collective experiences around core. So what we're gonna do, we have a very short time available in our session. So we're going to do what I'm calling the lightning round, and we're going to give each of our moderators 1 minute to give us the high level of importance of what emerged out of your session in terms of priority. So we'll start with you, Caitlin. The question was, how do we address who is systematically missed or never treated during MDA? Do you want to give us your high priority areas? Hopefully they're back. Oh, maybe they're not back yet. Okay.
Yep, everybody should be automatically rejoining now, Allison. So everybody had 2 minutes to come back.
Okay, so maybe what I'll do is I'll start with our group since I was in question 1. And we had a great discussion. The top emerging areas in terms of what can we try to address the systematically missed or the never treated. One was sharing information back to the community on levels of never treatment and the ongoing active transmission when that data is available, and measuring how that might impact future rounds of MDA, and particularly increasing the reach to those who are never treated. The second idea that emerged as really important is how to better use patient advocates to help drive participation in MDA in areas with levels of NT. And then finally, a dual one on stratifying levels of never treatment and social mobilization activities, as well as in-depth interviews with those who persistently refuse MDA to explore reasoning. So those were the emergent areas from question number 1. Caitlin, over to you.
Hi, thanks so much. So we had a great group. And we were looking at how we can be addressing MDA, people who were never treated during MDA, and we had a really rich discussion about what we know. And so we really saw that one of the most important things for us to be able to address never treatment is to really understand the context for never treatment. And people noted that that context really is going to vary across settings. It's going to be different in rural or urban. It's going to be different for different risk groups, which is something to consider, that what works well for farmers might not work well for traders or other groups. So really trying to understand the local context, leveraging local knowledge, both sort of at the district level, but also at the healthcare worker level, and recognizing that we need some bottom-up approaches is really critical for understanding the context. And so it's not until we understand the context and reasons for never treatment that we're going to be able to make any headway into actually addressing the issues. There was also a mention of making sure that we really coupled never treatment with other transmission parameters, like how, this came up in our discussion in the plenary, the challenge of people who might be missed both during surveys and during the MDA itself. And so there being a value in coupling never treatment with parameters such as antigen or mosquito parameters. So we had a long discussion, but I'll just leave it at those 2 for now. And yeah, thanks so much, Allison. Back to you.
Great, thanks, Caitlin. We'll go next to Molly, who will give us, start out with what are the systems level barriers and opportunities to address never treatment, and just give us some of your high level report backs. Thanks, Caitlin.
Yep, we had a great group, a very global group. We didn't get to necessarily prioritizing what we could try, but a couple of things that bubbled to the top were, One, this idea of co-creation of MDA with communities themselves, recognizing that can be time intensive and can be a little slow sometimes, but could be incredibly useful, particularly in areas where we're seeing never treatment. And then the other, this idea of the system level barriers of budgeting and getting budgets correct and in the right cycle, is that we really need to think about integrating this into the health system so that the people at the district and lower levels that are developing the budgets are part of the process, and it's not just a top-down process from the NTD program as it has been in a lot of countries. So how do we effectively integrate it into the health system so that we can have more accurate and easily used budgets?
Great, thank you. And just a time warning, we only have 6 minutes left. So Ernest, if you have anything to add to that particular same issue, I'm gonna cut you off sooner than we're gonna rush.
Right.
All right, go ahead.
Right, so I think we also identified that programs are often top-down. That is, the national level plans the interventions without engaging the communities. And that affects the availability of people. So that is very important. Programs should engage communities when they are planning. And one thing that also came up significantly was the packed public health calendars in countries. And these NTD programs need to work through carefully and plan ahead to be able to have opportunity. One of the ways they thought could be addressed this is we could evaluate other programs and see where we could collaborate with them. We have community health workers who go to the community to do one intervention or the other. Where we identify a challenge, can we integrate a particular intervention with an NTD intervention? And by so doing, we send out treatment to others. Then one of the areas is building capacity of community workers, especially resilience. I will go to one last point on other considerations. So we need to research the best ways of doing urban MDAs. That came up strongly that it has been a challenge, so we should have a good way. Maybe one last point, can we introduce some education on NTDs from the primary level, and people may understand it better. Thank you.
Thanks, Ernest. All right, Jejem, like 45 seconds. This is on collect, analyze, and use data.
All right, okay. So the very point is that the data is available, but how to analyze that information is not there. So there's the need to develop the tools to help analyze the data. Then that also leads to the point about the methodology that should be used in defining how the data can be analyzed. In terms of consideration, one important point was what time period should be used in defining never treatment. 5 years here, 3 years there. Should we consider the entire period the person has never taken the drug? That needs to be considered. And there is also the issue of capacity to collect the data by disease programs and to analyze them. So I think I'll leave it there.
Thanks, Jejem. Angus, like one thought, and Wilma, one thought, and then we'll close because they're going to pull us out of this room. So Angus, thanks.
Yeah, thank you. One of the things which came across in ours as well is sort of the differences that is going to be by setting in terms and the key role of CDDs in making sure that the approach that's taken to measure never treatment and understand never treatment in the setting is tailored for that setting, and so particularly suggesting further mixed method studies on things like gender differences or other differences, and particularly understanding things like spatial clustering. Another key problem is bias, and we didn't have a way to come up with this bias in understanding the people who are responding to these, surveys, etc. They might be the same people who are also taking the drugs, and so that inherent bias and trying to get around that, we didn't have a good solution.
Thanks, Angus. That's an important point. And Wilma, one 30-second thought. Sorry.
Well, we also identified the geographical clustering as an important factor. The other thing is that we really think that electronic data capture systems should be used to have timely information.
Wonderful. Gosh, rich stuff. Thank you. Thanks to our moderators. Sorry, I put you in a really tough position to report back in 30 seconds, some of you at the end there. Just to let you know, what we're going to do is compile the Easy Retro boards across the different sessions and send it out to everyone who's in this group. If you could just have a look and give us your priority areas. It's going to feed into meetings that are happening next month as we consider these issues and how we need to recommend the community move forward, and also to really, most importantly, support programs. So thank you to our speakers. Thank you to our breakout moderators. Thank you to Core NTD for supporting this session today. And thanks to everyone for participating in yet another Easy Retro board. Maybe it will be nearly our last ones. So thanks everyone, and wish you a lovely evening wherever you are, a lovely remainder of your day. And thanks for taking the time to talk about this issue today. And there we leave with probably 10 seconds to go. So enjoy the time. Thanks, everyone.
Thank you. Bye-bye.
Thank you.
Thank you, Alice.